Welcome to the debate. Today, we are opening the hood on one of the most routine yet deceptively complex tasks in clinical medicine, calculating a heart rate from an EKG.
Right. It feels like the first thing you learn, but it's fundamental. You see that number on the chart? HR 72 or HR 150. But how you get to that number involves a choice between two very different philosophies.
That's a great way to put it. We're debating the big box method, relying on that 300, 150, 100 sequence, versus what we'll call the strip method, which is just counting the R waves and multiplying by 6. So the central question is, when does that clinical precision matter more than a quick, holistic estimate?
And, on the flip side, when does trying to be a mathematician actually endanger your patient?
Exactly. Before we dive into the grid lines, this episode is brought to you by Whole Life Healthcare.
And just a reminder, if you want to follow along with, say, the UNC School of Medicine protocols or the NIH studies we're referencing, you can find those links right in the description.
So I'll start. I'm going to stake my claim for the big box method as the superior standard for the competent clinician. When you look at the source material from UNC, the EKG isn't just some drawing, it's a graph. It's voltage over time on a grid. To ignore that grid is to ignore the entire instrument.
Okay, I don't ignore the grid. I just don't, worship it. My position is that the strip method, counting R waves in a 6-second strip, is just the more practical, more robust tool. My whole argument is that the big box method, it works in a textbook where the heart beats like a perfect metronome. But in the messy reality of the ER, especially with those irregular rhythms our sources mention like atrial fibrillation, the big box method just falls apart.
All right, well, let's break down the mechanics so everyone's on the same page. My position rests on this idea of analytical decision-making from that NIH study. The big box method uses the paper speed. The paper moves at 25 milliliters per second.
Which means one large box is 0.2 seconds.
Exactly. So if 2 R waves are one large box apart, the rate is 300. 2 boxes, it's 150. 3 boxes, 100. Then 75, 60, 50, 43. This sequence, 300, 150, 100, it's not a guess. It is a mathematical derivation. When I use this, I'm getting the exact rate. And that is critical for telling different pathologies apart.
Okay, give me an example where that specific number actually changes what you do.
Look at the distinction between sinus tachycardia and supraventricular tachycardia, or SVT. The UNC source highlights this perfectly. A patient with sepsis might have sinus tach at, 140 or 150. A patient with a reentry circuit, SVT, often hits 170, 180, or even higher.
But you can see that difference. SVT just looks like a sheer wall of QRS complexes.
Looks like isn't a diagnosis. If I just count R waves in a 6-second strip, I might get about 160? Okay, is that severe sepsis or is it SVT? I don't know. But if I use the big box method and I see that the RR interval is exactly halfway between the second and third box marks, I can calculate a precise rate of 214. That number tells me immediately this is not sinus tachycardia. The precision of the big box method, it excludes one diagnosis and confirms the other.
I see why you rely on that for the regular rhythms. I do, but let me come at it from a different angle. The strip method, defined in the source as R waves times 6, is superior because it doesn't have the fatal flaw of the big box.
Which is?
The assumption of regularity. The big box method takes a snapshot. You measure the distance between beat A and beat B, and you assume every single other beat in that minute follows the exact same timing.
In a healthy heart, they do, for the most part.
But we aren't treating healthy hearts. We're treating sick ones. Let's look at atrial fibrillation. The UNC text describes it as having an undulating baseline and, crucially, an irregularly irregular RR interval.
Granted, A-Fib is irregular.
It's chaotic. So if I use your big box method on a patient with A-Fib, and I just happen to measure a short interval between 2 beats, I might calculate a rate of 110. Okay, but if I measure the very next interval, which is longer, I get 60. Neither of those numbers is the heart rate. They're both specific lies based on a single moment in time.
Lies is a little dramatic.
Is it? I think it's accurate. The heart rate, in a physiological sense, is how many times the ventricle pumps per minute. That's what determines cardiac output. The strip method, counting every R wave across 6 seconds and multiplying by 10, that gives you the average. It smooths out the chaos. It gives you the hemodynamic truth of what that patient is experiencing, not some mathematical projection based on 2 random beats.
I accept that A-Fib is the Achilles heel of the big box method. I do. But I'm not convinced that one exception, even a common one, invalidates the rule. The majority of diagnostic clues in EKG interpretation come from regular patterns.
You're calling the most common arrhythmia in the world an exception?
In terms of diagnostic mechanics, yes. Let's look at atrial flutter. The UNC source describes that classic sawtooth pattern. It's a macro reentrance circuit. The atrium is beating at almost exactly 300 beats per minute.
A fast loop, yeah.
It's a machine, and the AV node usually blocks this in a set ratio, 2-to-1, 3-to-1, 4-to-1. If there's a 2-to-1 block, the ventricular rate is 150, exactly 150, not about 140, not fast, 150.
So you're just looking for the magic number.
I'm looking for the signature. If I see a narrow, complex tachycardia and I put my calipers down and the big box method says 150 on the dot, my brain immediately screams flutter. Then I can look closer for those little sawtooth waves buried in the T waves. If I use your strip method, I count 14 or 15 spikes. I get a rate of 140 or 150, but I don't get that click of recognition. The math, the precision, it guides my eye to the diagnosis.
That's a compelling argument for flutter, I'll give you that. But I worry about the cost of that intense focus. The UNC text has this great line about the squiggly stuff you have no idea about.
A technical term.
Yeah. But it speaks to the reality of the unknown. My problem with the big box is that it promotes a kind of, tunnel vision. You find your beat on the heavy line, you count to the next beat, you do your math, and you stop. You've got your number. To visually track across the entire 6-second strip, you have to look at everything. And in doing so, you're much more likely to spot the oddball beat, that premature ventricular complex, or a quick run of non-sustained VTach, or the shifting P waves of multifocal atrial tachycardia.
MAT is a distinct entity, yes. The source mentions it with COPD.
Right, the 78-year-old with lung disease. MAT is defined by irregularity. If you just zoom in with your big box calipers, you miss that variability. You might just call it sinus tach and treat it completely wrong. The strip method forces you to see the rhythm as a whole.
I would frame that differently. I'd argue that relying only on the strip method promotes diagnostic laziness.
Laziness?
Yes. Look at the step-by-step approach in the UNC guide. It goes rate, rhythm, axis, intervals. We have to measure intervals. You need to know if the PR interval is longer than 0.2 seconds to diagnose a first-degree block. You need to know if the QRS is less than 0.12 seconds wide.
Sure, and you use the small boxes for that.
Exactly. You are already in the grid. You're already counting small boxes to measure QRS width. So if you're already looking at the grid to measure width, why would you suddenly pull back and just count spikes to measure rate? It breaks the workflow. It suggests you don't trust your ability to interpret the timescale of the paper. Using the big box method for rate is just the natural extension of a thorough analytical exam.
That assumes you have time for a thorough analytical exam. And that brings us to the crash scenario source.
The code blue context.
Right. This is where the debate shifts from what's elegant to what keeps the patient alive. The crash scenario literature focuses on these binary decisions. Is it shockable V-fib, pulseless VTach, or is it non-shockable, asystole, PEA?
Speed is paramount.
Cognitive load is paramount. That NIH paper on high-risk decision-making talks about recognition-primed decision-making. It's how firefighters and ER docs make split-second choices. It's based on pattern matching, not calculation.
Go on.
Well, when a patient is coding, your adrenaline is through the roof. Your working memory shrinks. Asking a clinician to recall 300, 150, 100, 75, and then trying to interpolate between boxes while people are shouting, you're just asking for an error. Counting 1, 2, 3, 4 spikes. Okay, rate's roughly 40. Start CPR. That's robust. It uses a lower level of cognitive processing, which is exactly what you need in a crisis.
See, I'm not convinced by that because it underestimates an expert's ability to analyze under pressure. The NIH study explicitly notes that analytical strategies were also prominent in high-stakes environments when the operator is trained.
But why add the friction?
Because the friction can prevent the wrong treatment. Let's talk about ventricular tachycardia. The UNC source defines it: greater than 30 seconds of wide QRS with a regular rhythm.
Fast and wide.
But regular, that's the key. If you have a patient who is unstable but still has a pulse, a crash scenario but not yet a full arrest, you have to decide, is this VTach or is this just sinus tachycardia with a bundle branch block?
And that can be a nightmare to tell apart?
Right. If you use the strip method, both just look like fast, wide spikes. You might end up shocking a patient who just needs fluids. But if you use the big box method, you can prove the regularity. VTach is monomorphic. It marches out with terrifying precision. Sinus tach usually has some slight variability. The big box method reveals that regularity. The strip method just blurs it.
I'm sorry, but if a patient is unstable, hypotensive, chest pain, crashing, I am not measuring RR variability to the millisecond. The guidelines are clear. Unstable with a wide complex tachycardia, you cardiovert.
That is the ACLS algorithm, yes.
The nuance you're talking about is for the stable patient. In the crash scenario, the strip method aligns with the survival brain. It gives you a good enough number to act on immediately.
Perhaps in the absolute extreme, I grant you that. But most EKG reading happens in a quieter setting, where we face a different enemy. And that brings us to that study from the Medical Journal of Australia on cognitive bias.
The negative history study, that was fascinating.
It's terrifying. They gave doctors EKGs, and when they gave a positively biased history, like hinting at the correct diagnosis, accuracy went up. But when they gave a negatively biased history, saying a patient with cardiac ischemia probably just had gastritis, accuracy dropped by 34%.
A third of the diagnosis missed just because of a story?
Exactly. The clinical story corrupted the visual analysis. And this is why I fight for the big box method. It is an objective, mathematical check.
How so?
Okay, let's say I have a patient who looks fine. My bias says, he's fine, it's just anxiety. If I use the strip method, I glance at the strip, it looks a bit fast, I count roughly, get 110, and I say, sinus tach, anxiety. My bias wins.
You confirm what you wanted to see.
But if I force myself to use the big box method, and I measure that interval, and I get exactly 150, I can't ignore that number. Math is stubborn. It overrides my bias. It forces me to stop and ask, wait, why is it exactly 150? Could this be atrial flutter? The rigor of the calculation protects me from the softness of the clinical history.
That's a strong point, but I interpret that bias study differently. It also talks about premature closure.
Locking in on an answer too early.
Right. My concern is that the big box method is premature closure. You pick 2 beats, you calculate the rate, you write it down, you feel good because you did math, and then you stop looking.
And you think the strip method keeps the eyes open.
I do, because you can't do the strip method without looking at the entire 6-second window. You are forced to scan the whole time frame to get your count. And in that scan, you're checking for consistency. You're seeing the context. You're less likely to anchor on one single clean interval and miss the ugly truth happening 3 seconds later.
So you view the strip method as a tool for situational awareness, not just for counting.
Exactly. It forces you to widen your aperture.
While we've covered a significant amount of ground here, we've gone from the mechanics of the grid to the psychology of the emergency room.
It's clear this isn't just about counting numbers.
So let's summarize where we stand. My position remains that the big box method, that 300, 150, 100 sequence, is the tool of the expert diagnostician. It's essential for regular rhythms like SVT and atrial flutter, where specific rate cutoffs really define the pathology. It aligns with that analytical reasoning we need to overcome bias, and it respects the EKG as a calibrated instrument.
And I maintain that the strip method, R waves times 6, is the tool of the realist. It's the only safe method for those red flag irregular rhythms like A-Fib and MAT, where the big box method just doesn't work. And in the high-stress, high-stakes code blue, it preserves your mental bandwidth, it aligns with that recognition-primed decision-making, and it stops you from getting tunnel vision on a math problem when you should be looking at the patient.
It seems the step-by-step approach that the UNC School of Medicine advocates for really implies that a complete clinician needs to be facile with both.
I can agree with that. You can't build a house with only a hammer. If the rhythm is regular and the patient is stable, yeah, pull out your big box calipers, be precise.
But if the baseline is undulating or all the alarms are blaring?
Then you count the spikes, you get the average, and you treat the patient in front of you. The choice of method really depends on the regularity of the patient's heart and the time pressure of the environment.
Complexity often requires multiple perspectives to fully appreciate.
And hopefully, we've given you a few new perspectives to take to the bedside.
Thank you for listening to The Debate. We hope this discussion has illuminated some of the nuances behind these two fundamental methods.
And remember, you can find the UNC guide, the crash scenario protocols, and that NIH research just by clicking the links in the description.
Until next time,